Good afternoon, everybody, and welcome again to this afternoon session. Today we have Dr. Karen Hubert. Dr. Hubert received her medical education from the Chicago Medical School. She completed an internship and residency in family medicine from St. Paul Ramsey Medical Center in Minnesota. That's, St. Paul, Minnesota. Dr. Hubert is board certified in family medicine. She is an instructor with the Wisconsin Medical Opioid Prescribing CME. Please, let's welcome Dr. Hubert.
Thank you. Thank you. Well, thank you. I appreciate the opportunity to come and talk to you this afternoon. Just by way of disclosure, so my background is family medicine. I'm also board certified in addiction medicine, and I actively treat patients with opioid use disorder in my clinic. So that's kind of the reference point that I have. I'm not an anesthesiologist, so I'm not here today to tell you, here's the medications that you need to use for this surgery or for this post-op time. What I'm hoping that we can do as we look at some of the objectives is to kind of frame post-operative pain a little bit differently, kind of bigger picture. So I'm hoping that what we get from this is, one, reinforcing some of the things that you're already doing, maybe giving you some ideas of some other things you might want to look into a little bit more with some of the recommendations from the American Pain Society, and then also kind of framing the bigger picture with the opioid epidemic and all the things that we're seeing in the news, and show you towards the end here some of the things that are going on at statewide levels that potentially impact how people look at opioid prescribing, because ultimately that's what we're getting to here. So the framework that I chose for the talk are the guidelines for the management of postoperative pain that came out and published in 2016. This was done by the American Pain Society, and it was a big collaboration of anesthesiologists with a big panel of experts that just combed through thousands of abstracts to kind of give you a consensus on approaches to pain management in a perioperative setting. Now that said, right, this is a guideline, and so it's not a directive, it's not something that says you must do this, but it gives you a framework. There are 32 recommendations, so you'll notice in the slides that what I've done is pull out the ones that are more pertinent for today. There's certainly some ones that pertain to pediatric medicine, which we won't really touch on. So some of them we'll go through fairly quickly. They're more there for your reference. One of the things that I would point out is that of the 32 recommendations, they were given strength of recommendations, so strong versus weak recommendations, and then quality of evidence. And of the 32, only 4 had high quality supporting evidence. So we could pick apart each one and look at the evidence and what they base their recommendations on. But I'm going to point out to you those big 4 that had the strong quality of evidence as well. So why do we talk about post-op pain? Well, in the literature, we know that certainly 80% or more of surgical patients are going to experience post-op pain. That seems rather obvious, right? And 70% might report their pain as moderate or more after surgery. The other interesting thing is how many actually report adequate pain relief and what happens when pain is not adequately controlled. So we know that affects the quality of life, it affects function, and their potential recovery. It also increases the risk of surgical complications and the risk that they continue on and have chronic post-surgical pain. So I'm typically a storyteller by trade, so I like to tell a lot of stories. So one patient that I have that I want to just kind of put his story out there as we think about how we approach these recommendations is I have a young man that I treat for opioid use disorder with Suboxone, and he's doing fabulous. But his story is kind of typical of many of the patients that I see. He was probably about 8 years ago. He was on his motorcycle. He was on his way to join the Marines, actually. He was on his way to the recruiting office, sideswiped by a truck. So this young guy ends up in the hospital for months. He's got multiple surgeries. You can imagine the amount of orthopedic trauma that he had. And while in the hospital, of course, treated well and given lots of pain medication to control his post-op pain, get him ready for the next surgery and the next surgery. But when he was discharged, you know, he was a young guy. A lot of the young guys, they don't come and see you as a primary care doc. He didn't have one. So when he was discharged, he was given a certain amount of pain medicine and they said goodbye. And there was really no good handoff for this young guy. So as he ran out of his pain medication, this is the story that we hear, right? He started buying more Percocet over the count, you know, on the street, trying to get more, gradually moved to heroin, and that was his story. So that's kind of that person that, as in some of this framework, talking about the pre-op education and then the discharge home, that's that patient that we're trying to prevent that happening. And not have that person progress on into that world. So, recommendation number 1 really focused on pre-op education and identifying those patients that are going to be higher risk coming in. And we know that people who have other medical comorbidities, the psychological comorbidities, and various social factors are going to be the patients that may be more challenging to control their post-op pain. The benefit of thinking about this ahead of time is potentially that they have less anxiety. They have a better idea going into surgery, what's going to be expected, how their pain is going to be managed ahead of time. So the more that we can educate them, that's going to set a different tone for the patients as they're coming in. Of course, we think about, you know, if we're doing pre-op evals, what are the medications that they should or shouldn't stop? What are the things that we want to avoid? For instance, someone who's chronically on a benzodiazepine, we don't want them to withdraw in the pre-op time because that's going to complicate the surgical and the perioperative management later. Recommendation 3 was, again, that pre-op time of looking for patients that might challenge us later on. So we think, okay, this is really what primary care should be doing, right? This is what I should be doing when I'm doing a pre-op eval of my patient, and thinking about how the fact that they have depression and anxiety, and they tend to have not so great coping skills, and maybe they're using a little more alcohol than they should be, that's going to affect surgery. It's going to affect what the surgeon does later. It's going to affect their post-op course and coming out. And so being more proactive in how we manage these patients. When we think about Wisconsin in terms of the opioid epidemic, and so today we're talking about opioid-naïve people. We could do a whole different talk on someone with chronic pain, on chronic opioids coming into surgery. So Wisconsin falls about in the middle in terms of the states, in terms of the opioid epidemic. We're about average. We're not the highest users and not the lowest. But what about alcohol? Where do you think we fall? So if I showed you a slide for where does Wisconsin fall for alcohol dependence or misuse, ages 12 and above? I can show you the CDC slide. Where do you think we fall? No, we're definitely in the top 10. We're in the top 10 of the states, right? So you guys aren't surprised by that. You know, looked at me like, aha, here we go. So thinking that I might see it, you might see a chart that doesn't say opioid use disorder. It doesn't say alcohol use disorder, right? But holy mackerel, there's a lot of people out there that fall somewhere in there and maybe just haven't been identified yet. So thinking about that ahead of time. Recommendation 5 is to use a validated pain assessment tool. These are all the different ones that you're going to see in the literature. The verbal pain, the numeric pain, depending on how you approach it. And that's what most of us are doing. But recommendation 5 also said that it's more than just quantifying pain. It's more than just, what's your number today? Are you at a 3? Are you at an 8? It's not just a number, but it's function. And so if we're looking at a patient and you're assessing their pain at rest, but not at activity, that's gonna make a difference later when you're trying to discharge someone home. So thinking about what is their pain at rest and then also with activity. Are they going to be able to participate in rehab? Are they going to be able to return to their normal function? Because here's where we're at, right? This is the challenge, that we want to be patient-centered, we want to treat people's pain, we know we've got to treat their pain, but we also have these other competing things. We've got someone in the hospital. If we don't treat their pain adequately, their hospitalization potentially gets prolonged, and they sit here, right? And once you discharge them, there's that competing thing of, well, I don't want to have them readmitted because they're in pain, so I need to treat their pain. How much pain medicine do I give them? How do I make sure their pain is treated at home so that they don't come back and get readmitted? So we have kind of these competing interests, and overarching want them to get better. The other thought of, as we're quantifying pain, is also to think about if someone is consistently rating a high level of pain and they're not responding to what your usual care is, thinking about, yes, do we have a new medical issue? Is there some type of complication? But also, have we missed something else? Is there an underlying disorder, opioid use disorder, or alcohol use disorder, or some other psychological thing that's there that's contributing to how they see their pain and how they communicate that to you? So recommendation 6 talks about use of multimodal analgesia. And this is the first one that has both a strong recommendation, but also a high quality of evidence kind of backing their recommendation up. So the idea is that using not just opioids, but other modalities to target different mechanisms of action, that the evidence shows that there's better pain relief when you use multiple modalities and you combine them, and that you likely have less opioid use, not zero, but you're going to have a lower amount if you add in some of these other things. Also, the idea that we incorporate around-the-clock non-opioid analgesics, so things like acetaminophen and ibuprofen that we'll talk about in a couple minutes, which seem kind of simple, but the idea that you're hitting different mechanisms of action so that overall their opioid use may be less. So then the next recommendations kind of focused on what are all these other multimodal choices that you might have. So things like TENS unit, which didn't have a lot of evidence behind it, but still a potential thing that could be tried. Things like acupuncture, massage, cold therapy, particularly like after orthopedic surgeries. Not a lot of evidence, but not a lot of harm if you tried them, so they kind of had a mixed reaction there. Number 9 was cognitive behavioral, so that's the things like relaxation techniques, guided imagery, different things like that. I don't know, at Frederick now on my last delivery on labor and delivery, the nurse said, do you want some essential oils? And I said, we've got essential oils? She's like, yeah, I'll be right back. She came out with some peppermint and lavender and put it in the room. And I said, well, this has really helped me relax as I was getting ready to do a delivery, but actually helped the patient relax, helped her nausea a little bit too. She still had her epidural anesthesia, but that added thing in the room actually really changed the dynamic from someone who was was getting really worked up, and her husband was like, I don't know what to do, and everybody just kind of relaxed for about an hour. So it was really, really interesting. So that's where some of those recommendations come, and things that might assist us. Recommendation 10 talks about using oral over IV for patients who can tolerate oral route. So the evidence showing that IV is not necessarily superior, and that post-op pain really often in that first 24 hours requires around-the-clock dosing. So you'll know that if we let pain build up till you have kind of this hyperalgesia type of situation, the patients are going to require a lot more opioids to get their pain under control if it's allowed to kind of ramp up to a point. If they come from the PACU to the floor and then the nurses are busy and pain meds aren't started, back when they could be maybe in the PACU, the patient's level gets to a point where it requires a lot higher doses to get them back down under control. So thinking about that, there was for a while some literature and some studies that looked at preoperatively administering opioids for patients to see if that would post-op decrease their opioid use. But most of the studies said there wasn't really a clear benefit to doing that. So I put in here one of the potential places that you can go to actually help calculate some starting doses. There's certainly a variety of calculators out there. This one is pretty good in terms of the replication, and it has a lot of extra information. So thinking about a starting dose for a patient, and this could be used in the hospital as well as in the outpatient setting. So you select your opioid, and then you put in the patient's weight. Actually is just to distinguish, is this an adult versus a pediatric patient? And then it gives you some suggestions for starting doses, and even further on, a lot more information about that particular choice of medication. So it gives you a place to start if you're thinking about oral versus IV medication for the opioid-naive patient. The second calculator on there is the opioid conversion calculator, which becomes a lot more complicated if you're converting someone, for instance, from a morphine PCA pump, where you're having to calculate their daily doses. But it gives you a place to start. And it allows you to select here for whether you want to decrease the dose by 25 to 50%, because we're trying to modify it because of incomplete tolerance. So we don't go from full amount of IV to full amount of oral. We drop it by, on average, 25 to 50%, and then start back up. So it's just one potential place that you can go. And then this is how they base their conversion table on kind of what are the equa-analgesic doses between parenteral versus oral. Recommendation 11 talks about not using IM, which really there's no good benefit to IM because it hurts to give them the shot. They don't get reliable absorption from the medication, so there's really no clear advantage to doing that versus oral versus your IV dosing. Recommendation 12 talks about using IV PCA, and this was moderate evidence. And that's just based on what are the clinical trials that have been out there. So particularly good if the patient's going to need more than a few hours. Again, you can do it consistently so that you can stay ahead of their pain. Some of the trials showed better patient satisfaction versus having the nurse come in and give them intermittent doses of IV morphine or Dilaudid, letting the patient have some control. So for opioid-naive patients, they don't recommend using a basal infusion. So, there was no improved analgesia, and if you think about it, the whole idea of a PCA, the intrinsic piece of it that helps prevent respiratory depression is that the patient is the one pushing the button. And if they become too sedated, then they're asleep and they don't keep pushing the button. And that's the inherent safety of a PCA. So when you add a basal infusion rate, that negates that. And so now you have a patient who is continually getting their IV opioid, and they're potentially sedated to the point of respiratory depression. So for opioid naive, not using the basal rate, there's a couple different styles to start a PCA, and you certainly have, you know, your anesthesiologist who can help you with what your routine is here. But the idea is, how do you appropriately titrate it to get that initial level of analgesia? So some of the anesthesia literature suggests that patients get the loading dose in the PACU, and then starting, you know, giving them that initial starting dose with lockout time, on average 6 to 8 minutes, and then monitoring them. And if your patients are saying, boy, I'm not, if they're getting consistently high scores and they're not getting their pain under control, that you think about a couple things. So, do they know what to do, right? Are they actually pushing the button adequately? Doing an equipment check. Not just assuming that they're not, don't assume they're getting the medication. Is there a problem with just the equipment in and of itself? And then confirm that the patient's been getting at least 2 to 3 doses per hour and is not excessively sedated. So once you've kind of worked through all of those, now, okay, maybe let's get their pain under control with a one-time bolus and increase my amount of my demand dose. And then monitoring for at least another 4 hours. So this takes you out a ways before you think about using that basal rate for the patient. And in that idea of multimodal, we're thinking that the PCA is not just your standalone therapy. If you're relying just on that, that you think about adding in some other things, round-the-clock NSAIDs, the continuous catheter techniques, all of those other things, so that it's not just PCA controlling their pain. Recommendation 14 talks about people who get systemic opioids that really, that the nursing observation of the patient is really superior to a pulse ox. So just having them on a pulse ox is not enough for monitoring. And especially if they're requiring some additional oxygen, you can't rely on the pulse ox to tell you that the patient is hypoventilated and that they're at risk of respiratory depression. So we really do need to rely on the nursing evaluation. So here's some of the risk factors for respiratory depression, things that initially seem obvious, like obstructive sleep apnea or someone with a head injury, but also thinking about someone who's been using benzodiazepines regularly, someone who's hypovolemic is more prone to that, or if they're at some level of renal failure. Recommendation 15 is our second one that has both the strong recommendation and high quality evidence, and that's the use of acetaminophen and NSAIDs, which we're all like, wow, that's really exciting because those have been around forever and aren't those all over the counter. But for patients without contraindications, there's actually good studies that suggest that using one or both could lower their amount of opioid use later, because they're both looking at different mechanisms of action, and so associated with less post-op pain. So acetaminophen, we have the both analgesic and the antipyretic activity, but In 2011, the FDA dropped us from 4 to a max of 3 grams, so you have to keep that in mind if you're doing round-the-clock acetaminophen. Thinking about what are the contraindications, thinking about hepatic toxicity, potential interactions with warfarin, so that might limit your use in a particular post-op patient. So IV acetaminophen, I don't know, is anyone using that here very much? IV acetaminophen? So it's been approved since 2010. It's been around for a while. There's advantages to IV because you get a peak concentration much more quickly than with the oral, and you get higher blood levels. Once you're out of maybe a 24-hour period and they're doing oral, then that might be the point to switch over. But the cost is often one of the things that hospitals will look at. So if everyone starts using IV acetaminophen, look at the dose difference. You're talking about on average $10 to $13 a dose versus less than 5 cents for oral. So if everyone's using a lot of it for prolonged periods of time, that's going to drive your pharmacy costs up quite a bit. But maybe thinking of it in the first 24 hours as one of your multimodal things that you add in. Journal of Orthopedic Trauma looked at a cohort of patients with hip fractures, and they used kind of a standardized IV protocol and showed really fairly good improved pain scores. But look, they're also using less opioids. They're more likely to participate in their PT and not miss their PT sessions, and it may even decrease their length of stay. So NSAIDs, that they have their analgesic effect is dose dependent, so going higher and higher doesn't give you more pain control. And we have to think about GI and CV risks. There's in their literature, in the American Pain Society's guidelines, they go through some of the literature that's looked at where are some of the risks for using NSAIDs postoperatively. Can we use it in orthopedic surgery? There's some mixed evidences about that in terms of bone non-union. Potentially not a good idea in colorectal surgeries, and then contraindicated in a CABG. So 16 looks at pre-op dosing of celecoxib or Celebrex, and so a couple potential doses here. Still has the potential CV risk, even though it's a selective NSAID. So a lot of studies on gabapentin, seem to be using gabapentin for almost everything, but some good evidence mixed with different surgeries about whether pre-op or post-op dosing could decrease the risk for pain. Particularly in some of these types of surgeries where we expect more post-op pain, those have been studied a little bit more about whether using gabapentin before or after surgery could decrease the intensity of post-op pain. So some of that evidence is more mixed, but something to consider. This is one of the more recent studies that was published in JAMA Surgery. Fairly small trial of only 422 patients, and they didn't really see a difference initially, but getting the patient off of opioids later was impacted, which is kind of interesting because in the addiction literature, we use gabapentin for patients that are in withdrawal from opioids. And so that's potentially where some of that effect is coming from, that you can wean the patient off of post-op opioids potentially easier. So I'm going to go through the next couple pretty quickly. These are just some of the ones that, again, talk about multimodal. So considering IV lidocaine infusions. local anesthetic infiltration. Some surgeries more helpful than others. Evidence is mixed. Recommendation, I didn't have recommendation 23 up there, which was to consider peripheral regional anesthesia, but both that one and this one about neuraxial analgesia, these are our third and fourth recommendations that had strong recommendation and high quality to suggest that using these other anesthetic techniques can reduce post-op pain and reduce post-op opioid use later. So I want to spend kind of the last bit of time talking about the final recommendation, which is number 32, which is discharge planning. So the idea that how we coordinate patients leaving the hospital on opioids, how that affects then their ability to get back to their normal function, but then also whether they go on to continue to use opioids chronically. And this is like a big area right now because with the opioid epidemic, everyone is looking for two things. How do we treat the people that are already having trouble? And how do we prevent this from happening? So everyone is looking at, is it primary care? Are you guys prescribing way too many? And is it post-op? Are they getting these big doses of opioids to go home with? So there's a lot of literature right now looking at where can we intervene? Where can we impact that problem by judiciously using opioids? So here's the CDC. They're invested, right? So they say, well, took a big sample, over 1 million patients. And this was about 10% of records that they looked at from 2006 to 2015. It was from a large managed care plan because they were trying to get an overall representative. And they wanted to see, is there a trend? Is there a way we can predict people who go on to use opioids chronically? So their evidence, just from looking at the records, showed that the likelihood of progressing on to chronic opioid happened. There was a jump that happened at the third day. So it's a third day of using opioids. Holy mackerel, that's not very long. There's a 5th day jump and then a 31st day. They also saw that the likelihood also increased if the patient got a refill, or they looked at a cumulative dose of how much pain medication they got in that post-op time. So here's kind of where you see that those jumps. And then particularly looking at that one out at 31, really increased that 1 year probability that the patient would, at 1 year, would still be on opioids. They looked at the number of prescriptions that they got, and that kind of makes sense if they were getting repeated prescriptions, that at 1 and 3 years, they're much higher probability. They also looked at what types of medications the patients were getting. So people who were started on long-acting, so maybe discharged from the hospital on a long-acting opioid, were more likely to have continued use. And everyone expected that. So I said, well, that makes sense that they might still be on it. But the initial treatment with tramadol was a surprise. And they didn't have a good explanation for why people who were started on tramadol, which is really a weak opioid at the mu receptor, it doesn't, we think of it as much weaker than, for instance, oxycodone, that those patients had a higher probability. So here's what the CD said, and the implications in quotes are my quotes, because the question is, how good is this in terms of really predicting anything? Because you just did a retrospective look. And so, but this is quoted. This is quoted in multiple articles. Well, the CDC did this big study, you guys, and it showed that if you authorize a second opioid prescription, that doubles the patient's risk of being on opioids a year later. Maybe. I don't know, right? Because if you think about just doing a retrospective look, and they even said, well, what were the potential downfalls of this study? Really, they just looked at cumulative dose, so they couldn't tell if the person was getting an increased amount or if they were being tapered. That wouldn't show up. And it didn't really show to what extent someone was being treated for a chronic condition, and that might have impacted things as well. So there's a lot of unanswered questions, but I'm showing you this because what happens is they do a study because people are really actively trying to figure out how to prevent opioid use disorder. And so we do a big study, and literally I came back to this one, I saw it quoted at least 3 or 4 times to justify what we're gonna do now. We're gonna tell you how much you can give your patient. We're gonna pass a law to say you can't prescribe more than X number of days. So they're using this information going forward, but we have to ask more questions about whether that's true or not. A study on hip and knee arthroplasties and how many patients filled more than one prescription 30 days out, and that number came out to about, in their study, about 7% who were still using opioids. And this, of course, is not overly shocking that if they were using it before they went into surgery, potentially just fixing their hip or fixing their knee didn't mean they were going to necessarily come off of opioids later. So it's a little more complicated than just, okay, limit the amount of opioids you're going to send somebody home on. Here are some of the things that in that orthopedic study they found were strong predictors of persistent opioid use. And a lot of these aren't surprising. If you think back to those pre-op slides, those were the things you were trying to pick up. Someone with those chronic issues, smoking and benzodiazepine use, someone who already we think has some addictive potential in their brain, that they may be more likely to be persistently using opioids later. So there's a lot of different prescribing policies across the United States. So Wisconsin, no limits. But what Wisconsin might be doing is actually letting other entities set limits. So I don't know, I just got something this week, Children's Community Plan, and it laid out a whole bunch of we're gonna only let you fill this, we're only gonna let you write for this amount. If you do this, you're gonna need prior auths now. So the entities might be invested in limiting the amount of pain medication. North Carolina is interesting. It's one of the ones that is in the literature right now because in January, they passed a law that said you are not allowed to write for more than 5 days worth for acute pain or 7 days post-op. And so now they're saying, well, how are we supposed to enforce that? I mean, it's literally a law that you can't give someone more than 7 days of pain meds in a post-op. So right now that's being kind of touted as one of the extremes and saying, well, how do we enforce that? Are you going to punish doctors? Well, how are you going to measure that? How are you going to monitor them? And then what are you going to do to them? And they don't have a good answer for that. But that's what happens as the idea of the epidemic increases. We got to do something. So let's pass some laws, but it doesn't really tell you what's going to happen down the line. So the last thing was, this was an idea published earlier this year in the American Journal of Surgery in kind of this, how do we frame post-op pain in a bigger sense? And so I thought it had a couple interesting points. So the first was, what we talked about. Looking at the patient, what is their risk? Having a conversation about post-op pain at the beginning how do you screen your patients? So, do I think every surgeon is doing this? No. But here's where I think we have to think about how do we evaluate patients preoperatively differently. And that's where I'm hoping to just sort of maybe inspire some ideas for you. Because we don't talk very well, right? A patient shows up in my office and they're going in to have, a lumbar spine fusion, and all I have is, I know what they're on, and I've got a name of a surgeon, and I have their date of their operation, but I don't have a lot of communication, and I don't know what their anesthesia is going to be, and I don't know what they're going to do post-op, right? And so we look at them, and we look at their meds, and we look at their EKG and their labs and say, what's your risk, and you're good to go. But then there's not a lot of back and forth communication. So maybe on the primary care side, I really should be doing this more, right? I need to really not just evaluate them medically, but thinking from a pain control, is this patient going to be tough for the surgeons and for the hospitalists or not? Setting the expectation for the patient that yes, you're going to have pain, yes, we're going to help you control it, but we're focused on function and not just giving you more pain medication. And thinking about what's their previous experience, because that's going to give us insight and kind of color what happens next. What's the pain plan? So from anesthesia, what's going to be the plan? Are they going to have, are they going to some of these other multimodal things worked in, and letting the patient know why we're doing that up front. And then kind of coming back to that patient I talked about in the beginning, how are we going to stop the opioids later? How are we going to know, yes, you need opioids, but something's going to happen after surgery when you're going to need to come off of the pain medications. So Secre looked at opioid-naïve patients and said, so if we refill their prescriptions, does that initial prescription after surgery matter? So the first thing they found was that, the docs are worried, because I'm going to give you enough pain meds, one, because I don't want you to have to come back. Because if you have to come back, someone's going to come and pick up a hard script, right? I can't just call in more oxycodone for you. So let's give them enough. They're like, what's enough, right? What is enough? I don't know. And what they found was that giving them higher amounts didn't affect follow-up refills. So if you gave them 30 versus 90 versus 120, it didn't really impact whether they call and ask for a refill or not. But what did impact it were these other things. Looks like we've seen those for the third time again, right? The same kind of things. So thinking about what's going to happen when the patient goes home and being more proactive. So I had a knee scope about 5 years ago, great orthopedic surgeon. My husband went to the pharmacy, filled the pain medication prescription, came home and handed me a bottle of Dilaudid 90. Like, holy mackerel, why would I need this amount? But that was the protocol that surgeon always did. And so he gave everybody this particular quantity, and I didn't use any of it, So thinking about how do we change that mindset of just this is the typical prescription, but making it particular to that patient and what risks they might have. And then at some point we talked to patients about how do you get rid of your pain medication. So when they did this study published in JAMA Surgery, they found that that's a large number of patients who didn't use all the opioids they got from surgery. So those are sitting there, right? Sitting in the medicine cabinet, because you're like, I paid for these, so maybe I'll need them someday, and you put them somewhere in the house. In that same study, they looked at patients, and 2 days out from surgery, only 5% were using those multimodal things. So the question of, are we being proactive and saying to the patient, yes, you're going home on these pain medications, but I still want you to keep taking your acetaminophen around the clock or the NSAIDs or whatever other things you're using. Because that's a very low percentage. And in a month, it was only 1%. So people just kind of dropped all those other things and kept taking their pain medication. And then the final thing is, when is this patient in trouble? So if they're continuing to request refills in the post-op time, what's normal? What strikes you as being high risk that this person's in trouble? So should they be referred to pain management? And then the parentheses are my addition, because that's going to be my bias, which is maybe it's not a pain management problem, maybe it's a substance use problem. Maybe previously unidentified, but that might be that. That might be what we're dealing with. And so being proactive to that patient and saying something's not right here, and not just cutting them off. So think back to my other patient. He probably got pain meds post-operatively, but at some point someone just said, you're done, we're not gonna write for anymore. And that might have been a couple months out, I don't know. But he was in trouble, and there was no handoff to someone who could help him. And then finally, just the last slide here. So this was an idea from this group looking at assessing and managing acute pain. And I thought that this was just really interesting. So this was an actual patient that they described in their article, and they said, okay, here's this gentleman who's a 67-year-old man undergoing bilateral total knees, and here's the plan we had for them. Like, isn't that fabulous? Wouldn't that be nice if everybody kind of came in with that? And that's maybe the pie in the sky idea. But if you think about it, at what points could we be really creating that kind of a plan for a patient and talking together and having, the surgeon and the anesthesiologist creating their plan, and then the primary care also adding to that and creating a better transition for a patient. And then at discharge, having a nice handoff so that we know that this isn't someone who's going to get into trouble. And if they do, we can intervene for them. All right, that's all I have for you. Thank you so much. If you have any questions.